Let me paint a picture. You're 68 years old. You feel good, walking every morning, sleeping through the night, keeping up with your grandkids on weekends. You go in for a routine checkup, nothing dramatic, just the annual visit your daughter keeps reminding you about. Your doctor glances at your numbers, nods, and says, "Everything looks fine. Let me just update a couple of your prescriptions while you're here." You leave with 2 new medications added to the 2 you were already taking. No explanation, no conversation. You trusted the process because the process felt responsible. 8 weeks later, you've fallen twice. Your memory isn't what it was. You're tired in a way that sleep doesn't fix. And every specialist you see looks at your medication list and says the same thing. Who put you on all of these? That story is not rare. It is happening in primary care offices across this country every single day. And the people it's happening to deserve better than a 12-minute appointment and a printed prescription. My name is Dr. Sarah. This channel exists for one reason: to give adults over 60 the honest information the system rarely has time to deliver. And what I'm about to share is something most physicians will not say out loud with the clock running. After 65, certain medications that are completely appropriate for younger adults become genuinely dangerous for older ones. The body changes, the liver slows, the kidneys filter differently, the brain becomes more sensitive, and a drug that worked beautifully at 50 can quietly cause serious harm at 70. Today, I'm walking you through 5 specific medications I would personally reconsider after age 65. I'll tell you what the research shows, I'll share what I've seen happen when these conversations don't happen, and at the end, I'll give you a framework you can use at your very next appointment. Stay with me through all 5. Number 3 surprises people most because it's something almost every older adult has in their medicine cabinet right now. And number 5 is the one most families never hear about until something has already gone wrong. Before we begin, where are you watching from today? Drop your city or country in the comments. I read every single one, and I genuinely want to know who's in this community. Before we get into the 5 medications, I need to give you one framework, because without it, what I'm about to say might feel alarming when it should feel clarifying. I call it the age shift window. Every medication was tested and approved based on clinical trials, and the overwhelming majority of those trials enrolled patients between the ages of 40 and 65. That means the dosing, the safety profile, the expected side effects, all of it was built around a body that isn't yours anymore. After 65, 2 things shift in ways that change everything. First, your kidneys clear drugs more slowly. What's a normal dose for a 55-year-old can quietly accumulate to a dangerous level in a 72-year-old, not because you took too much, but because your body can't move it out fast enough. Second, your brain becomes significantly more sensitive to medications that affect the central nervous system. Drugs that cause mild sedation in a younger adult can cause profound confusion, balance problems, and memory disruption in someone over 65. That's the age shift window. Keep it with you as we go through each one. Drop your name in the comments before we go further. I go through every single one. Medication number 1. Sleeping pills, especially benzodiazepines and Z-drugs. Let me tell you about Margaret. Margaret was 68, a retired school principal from Central Ohio. Sharp, organized, still volunteering 3 days a week at the local library. She'd started having trouble sleeping after her husband passed. Completely understandable, completely human. Her doctor prescribed a short course of sleep medication to help her through the worst of it. That was 4 years before I heard her story. By the time someone sat down and looked at her full picture, Margaret had been on that medication continuously for 4 years. She'd had 2 falls, one that fractured her wrist. Her daughter described her as foggy. She'd stopped driving because she didn't trust her own reflexes anymore. She thought it was just aging. It wasn't. It was a prescription nobody had revisited. Here's what the research shows. Benzodiazepines, diazepam, lorazepam, temazepam, and Z-drugs like Ambien, known as zolpidem, are explicitly listed on the Beers criteria as medications to avoid in older adults. The Beers criteria is the American Geriatric Society's evidence-based list of drugs that carry disproportionate risk after 65. This is the consensus of geriatric specialists nationwide. In older adults over 65, these medications increase fall risk by roughly 50%. They double the risk of hip fracture. They are independently associated with cognitive decline. And because older adults metabolize them more slowly, the grogginess doesn't just affect bedtime, it bleeds into the next morning, the next afternoon, the next week. What to do instead? Cognitive behavioral therapy for insomnia, CBTI, has been shown in multiple studies to outperform sleeping medication for long-term sleep quality with no side effects and no dependency. Consistent wake times, reduced evening light, addressing underlying anxiety or grief, that's the foundation. The conversation with your doctor starts with, "Is this still appropriate for me at my age, and what's our plan to reassess it?" Medication number 2, anticholinergic drugs, the hidden cognitive threat. This one is harder to recognize because anticholinergic isn't a drug name. It's a property that dozens of common medications share, and most patients have no idea their prescription carries it. Anticholinergic drugs block a neurotransmitter called anticholinacylene, which is central to memory and cognitive function. In older adults, this blocking effect is amplified dramatically. The list includes things you'd recognize immediately. Diphenhydramine, the active ingredient in Benadryl and most PM sleep aids. Bladder medications like oxybutynin. Some older antidepressants, certain anti-nausea medications, some muscle relaxants. A landmark study published in JAMA Internal Medicine followed thousands of older adults and found that cumulative anticholinergic exposure was significantly associated with increased dementia risk, and that this risk persisted even after the medications were stopped. A medication you reach for regularly may be accumulating a neurological debt that doesn't announce itself until it looks like aging, until it looks like a diagnosis that changes everything. I think about Gerald, 74, retired from rural Alabama, sharp his whole life, started showing memory lapses his family attributed to normal aging. When someone finally reviewed his full medication list, he'd been taking a bladder control medication with strong anticholinergic properties for 6 years. Nobody had flagged it. Nobody connected the cognitive changes to the prescription. What to do instead? Ask your doctor or pharmacist to run an anticholinergic burden review of everything you take, including over-the-counter medications. There are scoring tools that quantify your total load. Newer bladder medications exist with far lower anticholinergic profiles. The first step is simply knowing the word and asking the question. If you're still with me, type the number 2 in the comments right now. It helps this reach people who need it. Medication number 3, proton pump inhibitors, the long-term problem nobody warns you about. This is the one that stops people. Omeprazole, pantoprazole, esomeprazole, Prilose, Protonox, Nexium. Prescribed for acid reflux, GERD, ulcer prevention, and they work for short-term use in the right patient. The problem is what happens when short-term becomes indefinite. These drugs were designed for 4 to 8 weeks of use. Studies consistently show a substantial percentage of people started on PPIs are still taking them years later without any reassessment of whether they still need them. Stomach acid isn't just a source of discomfort, it's how your body absorbs magnesium, calcium, B12, and iron. Suppress it for years, and you quietly develop deficiencies in the very nutrients your heart, bones, muscles, and nervous system depend on. Long-term PPI use has been associated with bone fractures from impaired calcium absorption, dangerously low magnesium causing heart rhythm irregularities, B12 deficiency that mimics cognitive decline, and increased susceptibility to C. difficile infection. Beverly was 72, a retired nurse from the Pacific Northwest who knew her way around a medical chart. 9 years on a PPI, originally prescribed after a stressful period. She came in with fatigue, muscle weakness, and brain fog she couldn't explain. Critically low magnesium, depleted B12, bone density lower than expected for her age. 3 separate symptoms, 1 medication, not one reassessment in nearly a decade. What to do instead? If you've been on a PPI for more than 8 weeks, ask your doctor, do I still need this? For many people, a lower dose, an H2 blocker, or dietary modification manages symptoms without the long-term risks. Don't stop abruptly. That causes rebound acid. Have a planned, supervised reassessment. That's all this requires. Medication number 4. NSAIDs taken regularly for chronic pain. Ibuprofen, naproxen. So familiar, so available that most people don't think of them as serious drugs. You can buy them at any gas station. That familiarity is exactly what makes the risk invisible. For a 40-year-old with occasional back pain, periodic ibuprofen is reasonable. For a 70-year-old taking it daily for arthritis, the picture is entirely different. NSAIDs inhibit prostaglandins, compounds that cause inflammation, but those same prostaglandins protect your stomach lining, regulate blood flow to your kidneys, and maintain fluid balance. Suppress them chronically, and you're removing protection your aging body cannot easily replace. Regular NSAID use is one of the leading causes of gastrointestinal bleeding in adults over 65, bleeding that can be significant before any symptom appears. NSAIDs impair kidney function in a population where kidney reserves are already reduced. They raise blood pressure, blunt the effectiveness of blood pressure medications, and carry an elevated cardiovascular risk that compounds with age. Robert was 76, a retired contractor from North Carolina, still doing light woodworking on weekends. Daily over-the-counter naproxen for knee pain for 3 years. He never mentioned it because to him it wasn't a medication. He was admitted with a gastrointestinal bleed requiring transfusion. His kidney function had quietly declined. His blood pressure had been creeping upward for 2 years in a way his doctor couldn't explain, until someone asked about everything he was taking, not just what was prescribed. What to do instead? Topical diclofenac gel delivers anti-inflammatory effect with a fraction of systemic exposure. Acetaminophen, within dosing limits, is significantly safer for most older adults. Physical therapy and aquatic exercise have solid evidence for osteoarthritis pain. For most adults over 65, daily oral NSAIDs don't clear the risk bar. Type the number 4 in the comments if you're still here. I read every one. Medication number 5. Antipsychotics prescribed for sleep or agitation, the one most families never see coming. This conversation almost never happens until a family is already in a hospital room asking how things got this far. Antipsychotics, quetiapine, haloperidol, risperidone, were developed for serious psychiatric conditions. In those contexts, they serve a legitimate purpose. What the FDA has specifically black-boxed with a warning is this: antipsychotics given to older adults off-label to manage sleep difficulties or mild agitation carry a significantly increased risk of death. The warning is explicit. The risk is real, and these medications continue to be prescribed at rates the research community has called alarming. Here's how it happens. An older adult becomes restless at night or difficult to settle. A busy care team prescribes quetiapine in a low dose, framed as mild, as a sleep aid. The family doesn't know what it is, the patient can't fully advocate for themselves, and nobody explains that in an elderly brain, this drug increases stroke risk, accelerates cognitive decline, causes dangerous falls, and in clinical trials increased mortality by a significant margin. The documented outcomes, the falls, the strokes, and the accelerated decline, are not rare complications. They are statistically significant findings across large populations, happening to people whose families were told the medication was nothing serious. What to do instead? Structured daily activity, consistent routines, reduced evening stimulation, addressing pain that may be driving restlessness, these have real evidence behind them. If medication is genuinely necessary, safer options deserve to be explored first. And if an antipsychotic is being proposed for someone in your family, ask directly: why this drug? What non-drug approaches have been tried? And what does the FDA black box warning mean for someone her age? The 5-question protocol. Every time your doctor proposes a new medication, or when you look at something you've been taking for years, bring these 5 questions. Write them down. Put them in your phone. Bring them to every appointment. 1. Was this medication studied in adults over 65? If not, the conversation needs to be more careful. 2. Does this appear on the Beers criteria? Your pharmacist can answer this in 60 seconds. 3. How does my kidney function affect how this drug behaves in my body? This tells your doctor you understand the age shift window. 4. What's the plan to reassess this in 6 months? Medications should continue because someone actively decided they still make sense, not by default. 5. What non-drug alternatives exist? For pain, sleep, anxiety, blood pressure? The evidence for lifestyle interventions in older adults is stronger than most 15-minute appointments allow time to explain. Any physician who is paying attention will welcome these questions, and if a provider makes you feel difficult for raising them, that is important information about whether that provider is thinking about your whole picture. There is a version of medicine that treats an older adult as a collection of conditions to manage and symptoms to suppress. And there's a version that treats you as a person with a life worth protecting, your independence, your clarity, your ability to do what matters to you. After 65, you deserve the second version. The medications I talked about today are not villains, they are tools. What they are not is decisions that should be made once and never revisited. Your body at 70 is not your body at 50. Your medication list should reflect that. You have the right to know what every prescription does. You have the right to ask whether you still need it, and whether the benefit is worth a risk you may not have known you were carrying. If this gave you something real, please subscribe. I make videos like this every week, built around health questions adults over 60 actually need answered. Leave a comment below. Have you ever been on a medication for years that nobody revisited with you? Your story might be exactly what someone else needs to hear before their next appointment. And if this reached you, help Dr. Sarah reach 1,000 subscribers, because this is exactly what 1,000 people need to hear. Take care of yourselves. I'll see you in the next one. This video is for educational purposes only and does not constitute medical advice. Always consult your physician or a qualified healthcare provider before making any changes to your medications.